Hello, everybody. Welcome to another edition of Brain Trust Conversations in Psychopharmacology. I'm Joe Goldberg, your host. I'm a psychiatrist in New York at the Icahn School of Medicine at Mount Sinai. A pleasure to have you join us today for another conversation on topics in psychopharmacology that you may not necessarily have at the front of your mind, but you probably should be thinking about. And so part of our hope in chatting with colleagues in the field is to just spur your thinking and inspire more thought and reflection about what it is we do when we're seeing patients and prescribing medicines that make us even more mindful of what we're doing. And today's topic, I think, will be a real treat. We're going to be talking about the placebo effect, friend or foe, something that we can call upon and be cognizant of in deciding what really accounts for the benefits or lack of benefits we see in our patients, and how much are those benefits that we perceive truly pharmacodynamic events as opposed to, well, non-pharmacodynamic events. So our guest today, a real treat for me, a personal hero in the psychopharmacology space, Dr. Walter Brown, from Brown University, where he's professor emeritus of psychiatry and human behavior. Dr. Brown's had a very illustrious, long career in psychiatry, psychopharmacology, really for a number of decades. He's done an enormous amount of work in mood disorders, in psychopharmacology. He's written some really important things on lithium. I think you did a biography of John Cade.
It started off that way, but it turned out to be the story of lithium's discovery, but a lot of it was a biography of John Cade, yes.
Which gets us into the weeds of how these things come about, how observations get made. So, Dr. Brown, welcome to our program today. Thanks for taking the time to join us.
It's a pleasure to be here.
So I guess I'll ask you the same question you must have posed about John Cade when you were thinking about his work. Is how did he get interested in this area? So your interest in the placebo effect. Tell us how that came about.
It came about actually through some work I was doing in clinical psychopharm. I started off in my career, I wanted to find out what's going on in the brain and psychiatric illness, and I was doing a lot of studies. At that time, we didn't have brain imaging, but studies of neurohormones and growth hormone and things like that. I got very interested in the dexamethasone suppression test, which was something that was widely used and then abandoned. And I was interested in basically the broader topic of biological psychiatry, what gets people depressed, what's going on in their brain, et cetera. And through that, I started getting involved to some extent as a side issue in conducting clinical trials of new antidepressants. So this was in the 1980s. And, I was involved in a number of the original studies of the SSRIs, Prozac, and so on. And one of the things that caught my interest was how large the placebo effect was in these studies. Particularly when you're doing studies of antidepressants, there was very, very little difference, and that's actually the case today, between the degree of improvement that you got with one of the newer antidepressants or the older ones and the placebo treatment. All of these studies were then placebo controlled. Maybe 58 or 60% of patients would improve with a drug, the real drug like sertraline or Prozac. But 40% or 45% were getting better with placebo. And that intrigued me. And so I started to sort of look into whether we could tease out who were the people getting better with placebo and who not. Was there a clinical profile that could identify these people? And there really wasn't an easy one. There were a couple of minor symptomatic differences between the placebo responders and the non-responders, but not much. And so that got me just interested in the placebo effect, and I began to basically do two things. I was involved in a number of large-scale studies with collaborators looking at the patients who got better with placebo in these clinical trials. So we had a lot of data on them, and we were looking at whether they were symptomatically different than the people who didn't. But I also just got interested in the placebo response in general. and started reading a lot about it, and so on and so forth. And that was in the late 1980s. And for the next 30 years, I was doing other kinds of research. Uh, as you said, I wrote a book about lithium, and I was doing other kinds of so-called, biological research in psychiatry. But I continued to be interested in the placebo effect and read about its history and read a lot about various ideas about how it works and wrote a good number of papers about it. In fact, uh, without want to obnoxiously blow my horn too much, I wrote a paper that became very widely cited about whether or not you could use placebo as a treatment for depression. And that got
You
a
advocated it should be a first line treatment. You wrote an important paper in neuropsychopharmacology some years ago
right,
saying,
right,
look, these
right,
drugs work like 80% as good as the pharmacodynamically
right.
active version, but they have fewer side effects. Placebos are not devoid of side effects. But I think, were the first person who said, why don't we start there?
Right. It made sense to me. Not everybody who read that paper was enthusiastic about the idea, to say the least. But it's been, reprinted many places and so on. So that's how I actually got interested in the placebo effect, and I did a lot. A lot of it was studies that I did of patients in clinical trials, looking at those who got better with placebo and those who didn't, and see if I could tease out any differences. But a lot of it was what I would call, I don't even know what to call it, library research. I mean, I just looked into the literature, old and new,
Mm-hmm.
about placebo. And I did that for 20 or 30 years. And then in 2013, I put everything I had learned into actually a small book called The Placebo Effect in Clinical Practice. And I put everything I'd learned into that. So, and in the context of doing this sort of extensive literature reviews,
Mm-hmm.
I came up with some concepts about how placebos might work and how to define them that I then put out there.
You've said in writing expectancy is a big part of this
Well,
phenomenon.
yeah, and I'm not the only one. Expectation is the most widely studied aspect of the placebo mechanism, far and away.
Can you elaborate on that for our listeners who may be unconsciously aware of interacting with the patient's expectations, but not realize how they're doing that?
Yeah. In fact, it's so important that I think the National Health Service in the UK has recommended in an official commission report that medical students should be taught about about the importance of expectation. Expectation really means, that what you think is going to happen as a result of a treatment actually does. That your anticipation of an effect actually brings on the effect. And even though people have been studying expectation for a long, long time now, and systematically, certainly for several decades, nobody really knows how it works. Uh, how is it that the thought that you are getting coffee in a drink, caffeine in a drink, creates all of the physiological features of actual caffeine, even when you're not getting it? How did Nobody really knows how that happens. What happens on it? What happens in the brain when you say, what I'm drinking now is vodka, but when in fact it's placebo vodka, but yet you become intoxicated.
Mhm.
How does that happen? That's what expectation is all about. Irving Kirsch, who's a psychologist, has done a lot of work on the placebo effect, thinks that expectation may be a sort of fundamental non-mediated brain mechanism. That is, when you have a thought about what's going to happen, that somehow triggers off some brain process that makes it in fact happen. So anyway, however it works, it's a very, very powerful phenomenon.
I wonder if go ahead, I'm sorry.
And you know, the sort of you know, one of the fundamental studies of expectation, which really probably does not deserve all the attention it's gotten, but one of the fundamental ones took place in the early 1960s, and I don't know if you've heard about this, and it was published in a good Japanese medical journal. It came from Japan, and the investigators who were interested in psychosomatic medicine took 13 boys who were sensitive to the Japanese lacquer tree leaves, sort of like poison ivy, and they would get rashes if they were exposed to these leaves. And they brushed leaves from that were harmless, that weren't these poisonous leaves, on their arms, and all of them got the rash, even though the leaves were innocuous, but they were told that they were the poisonous ones. And for the same boys on another arm, they put the poisonous leaves, but told them that they were harmless. And only two of the 13 got the rash. So what that showed was that the thought that you were going to get exposure to something like a poison ivy leaf had a more powerful effect on your tendency to get a rash than the leaves themselves. And that study has been widely quoted. It's never been replicated, and I don't know if anybody's tried to replicate it. And it's so out there. I mean, how does a thought produce a rash? It's so out there that, you know, it's hard to believe. It sounds more like science fiction than science. But there you have it, and it's been widely quoted.
I guess the brain talks to the immune system, and
have
a deal going.
Yeah, something like that. So, but in any case, there's a library worth of studies. Most of the laboratory work in expectation has been with caffeine, with coffee, giving people drinks that they are told contains caffeine but don't. Alcohol, same thing. And there have been a lot of studies of, not as quite as many, but a number of studies of patients with asthma, giving them bronchodilators, but telling them that they're bronchoconstrictors, and they have trouble breathing, giving them bronchoconstrictors where they have trouble breathing, and telling them that they're bronchodilators and their breathing improves, showing that the effect on the respiratory tract also is very vulnerable to expectation. So a lot of the expectation work has come out of placebo studies, but it's also true that expectation has been shown to have a powerful influence when you're giving people real treatment. For example, about 15 years ago, there was a study. Am I speaking too quickly?
No. I'm hanging on every word. Keep going. My expectations are being fulfilled. So keep it going.
A couple of decades ago, there was a study of focused on St. John's wort. And about 100 patients were given either St. John's wort, sertraline, or a placebo. And it was double-blind, randomized, etc. When the results came in, everybody got a little bit better, but there was no difference in outcome. According to what somebody got, St. John's wort or sertraline or placebo. But when people were asked to guess which substance they had gotten, the ones who guessed that they had been given placebo, even if they'd been given one of the other things, did worse than the ones who guessed that they had sertraline or St. John's wort. And the ones who guessed that they were given St. John's wort or sertraline did better than those who guessed that they'd been given placebo, irrespective of what they actually received. And the authors concluded from this that the belief in what treatment you're getting has a more powerful effect than its actual pharmacologic activities.
Now, if I may turn
If
it
you
on.
follow that, if you
Yeah,
follow
no, no, very, very, very much so. And I think especially in a psychiatric population where we're dealing with not just, let's say, the phenomenology of something like depression or anxiety, but expectations come into play on so many levels, and not the least of which would be the therapeutic alliance. So if I can turn things on its side for the moment, placebo means I will please.
correct.
What if the expectation is I will disappoint? What if the expectation is you're the seventh doctor in a row that I've come to, and I don't expect much from you? I don't think you can help me one bit. Some people have written about sort of trying to turn this on its side in a paradoxical sort of way. And rather than over promising and risking under delivering, if the patient kind of makes it clear, I've got negative expectations in mind. One of my former mentors, Jerry Clearman, and Nick Ward, wrote some nice things about the idea of using paradox or paradoxical injunctions to sort of set the expectations a little differently. And I'm not sure that I can help you. Almost wondering if your expectation is you're going to defeat me. You're going to show that I can't help you either. The only thing I could do is give you something else to defeat, which is to dare you to get better. If you know that kind of viewpoint, I'm curious if you have any thoughts about manipulating the placebo effect in that way based on the person's expectations.
It's a complicated question because, as you allude, there are people out there who don't want to get better, who want to defeat the doctor for complicated psychological reasons. And whatever you give them, they fail at. So, I mean, I think my answer to you is not so much about placebo, but on how to manage somebody like that, and you've sort of touched on this, which is not to promise that they're going to get better because they don't want that. But to say something like, I'm going to give you X, it may not work. But it may not work, and in fact, it's likely to give you some side effects. Hopefully, they won't be too awful. But let's give it a try. In other words, you don't, for people who really want to defeat you, telling them that they're going to get better is as you say, is feeds into the paradox. It's not going to work. But what you actually are touching on, and I don't think I'm answering your question actually, but what you're touching on is what's been called the placebo effect's evil twin, which is the nocebo effect, which is that where people, nocebo means I shall harm, and it's where people experience detrimental things as a result of negative expectations. And I don't know if that's getting you.
Yeah, that's actually where I was going with this. In our field, a colleague, Art Barsky, has written a lot about the bad things that can happen. And it's never ceased to fascinate me as a psychiatrist when a patient is given something that we think is at worst benign, and they attribute harm to it. And they now have a tangible object. It's almost like a psychological scapegoat in a way that I'm suffering. And now you gave me this. And now I've got something I can hold on to tangibly. I mean, it gets into all sorts of interesting psychodynamics, but when I think about the placebo effect and the nocebo effect and the therapeutic alliance and how to use this, if you're in a research trial, you're trying to minimize the placebo effect, you're trying to maximize the difference from drug. If you're a clinician, it's the opposite, right? You're trying to get every morsel out of the non-pharmacodynamic effects. So it's always seemed to me that a really good pharmacologist knows how to do that, knows how to size up the dynamics and the expectations, and in a way figure out what the person wants. Do they want to not get better? Do they want to have some tangible sign of their suffering, and thereby get some sense of validation? And here's a way to say, wow, you're really suffering. Let's not dispute the fact that you are in pain and you're suffering. And I humbly offer myself up. I want to help, but I don't know if I can. So it gets at the psychology of prescribing in ways that go beyond just, drug versus placebo.
Well, yeah, I think, and again, I apologize. I don't think I really answered your question about what to do with the patient who comes to you with negative expectations. I don't have a ready answer for that, but what I can tell you is that, in terms of trying to help people who exactly what you can do, part of the management of patient expectations is to try to elicit from patients what they think, what their history of treatment has been, and what they think will work for them. And because most people have some, it may be spoken, explicit or unspoken idea of what they need or what will work. And if the patient really comes to you with some kind of depression, and underneath it all feels that what they really need is a pill and not talking therapy, that's important to hear from them and to know about. Or if people, and there are hundreds of thousands of them like this out there, really are adherents of alternative medicine and think that what would be good for them is magnetism or something like that. I think as a sophisticated psychopharmacologist, you need to know that and build that somehow into your management approach to this patient. I don't know.
Back to expectations.
Yeah.
And they may not even know what they're expecting. I mean, in a way, a good clinician sort of helps the person figure out what is it you think you need.
Right, exactly. I would also say that as much as, you talked about this earlier, as much as it's important to enhance the placebo effect, and you said, as you said, in research, in drug trials, we want to minimize the placebo effect, but in clinical practice, you want to maximize the hell out of it. I'm not sure, I think you may have a more optimistic view of what the typical psychiatrist prescribing pharm does to do that. I'm not sure that the overwhelming majority of psychiatrists do what they can to maximize the effect. Hopefully they do. And a lot of the maximization takes place non-deliberately, just being there, looking like a doctor, using the rituals and symbols of healing, all of those things will enhance the placebo effect of whatever treatment you give. But what I was, and that gets me to, one of the things that I emphasized in some of the things I've written is, when you think about placebo, whenever somebody's getting a placebo, they're getting much more than a sugar pill. They're getting all of the common elements of treatment minus a actual quote real treatment. So some people have thought that it's these common elements of treatment: evaluation, a chance to talk, mobilization of hope, stuff that Jerome Frank talked about. That it's all of those things that really make up the placebo effect, and I agree with that. I think a more evocative term than placebo effect would be the response to the treatment situation, and all of the things that go on in that. But I'm jumping around here. But to get to the
this is perfect. Actually,
to get to the nocebo, I'm sorry.
No, I think we're right on target. Keep going.
To get to the nocebo effect. So the nocebo effect is what people experience in terms of harm as a result of expectations. The typical thing, and the most powerful example, is side effects. When the more that people know about what side effects to expect, the more side effects they get. And that's been shown many, many times. And it was shown very dramatically with the COVID vaccine, where in the early phases of vaccine development, there were placebo-controlled trials. And, something like 50% of the patients given the vaccine got various kinds of side effects, most of them not significant, pain on injection, some fatigue, some malaise. But the people who got the placebo vaccine, just saline, also had a very high incidence of these side effects. So how much information people are given is a critical factor here. And it's been shown in studies of like sexual dysfunction side effects. If patients are told about that, they're more likely to get them than if they're not. And so there's really, and this has not been discussed very much, a kind of an ethical dilemma here, because you want to first do no harm, but telling people about side effects that they can get can produce harm because people to get those side effects that they hear about. But you also need to respect patient autonomy. And so people should be told what's going on. So there've been a number of, for people who are interested in this kind of thing, of attempts to get around this ethical dilemma. One is to frame side effects positively. And that has been shown to have some effect. In other words, don't say to people 10% of patients get constipation with this. You say 90% of people don't get any side effects, for example. Another approach has been what's called authorized concealment, where you say to people, I will tell you about the most serious side effects, but because, if I mention every possible side effect, you actually tell people that may influence what happens to you. Is it okay with you if I don't tell you about every little one? It's called authorized concealment. And some people have felt that that's a useful approach to this nocebo problem.
It's fair to say that some people might also think, well, I'm glad I'm getting a side effect because that must mean that the stuff's going to work. In fact, if I don't get a side effect, maybe you gave me a lame treatment.
Absolutely. And that's another sort of way to positively frame side effects. You say, the fact that you're getting diarrhea the first week or that, your vision is a little blurred means that the drug is working.
Yeah.
Sometimes that's true, sometimes not, but it means that the drug is working, makes those side effects more tolerable for patients.
You reframe it.
Yeah, it isn't that they don't get the side effect, but they tolerate it better and they're less likely to want to suddenly stop the drug.
I know patients who get ketamine and they're disappointed if they don't dissociate because they figure, well, it's probably not going to work.
Right. And Barsky, I'm glad you mentioned him, did some great work with side effects, and he actually identified two psychological mechanisms behind the nocebo effect. One was amplification of symptoms.
Mm-hmm.
That if you know that the COVID vaccine is likely to give you a headache, you are more likely to pay attention to a minor headache than if you don't. That's symptom amplification.
Yeah.
And misattribution, that most of us, particularly as they get into my age category, have aches and pains all the time, other kinds of non-specific effects, that if you are told that there's certain side effects of the drug, you will attribute them to the treatment you're getting, even if they have nothing to do with it.
You get into trouble with people with somatic symptom disorder or highly somatizing patients.
Right.
Can you say to you about that population?
Yeah, Barsky has talked about that also. Another way of approaching side effects is to tailor what you tell patients to the context. So if somebody is a big somaticizer or has had a lot of side effects in the past, that should tailor how you approach the information you give them. So, you don't want to tell them about every possible side effect. You don't want to make it scary. So you need to keep into account that sort of thing.
Mhm.
Absolutely.
Oh. Now, we've been making better placebos over the years, haven't we? The placebo effect in depression's kind of been in the 30-40% range, but the studies that go back, I guess, since the advent of the SSRIs and beyond seem to hint that, well, we're making better drug effects, but also better placebo effects. The difference may not be as salient, but my question is, how can our listeners make the best possible placebo imaginable in their clinical work with patients? What are they not realizing? Sort of hinted at some of this about how you come across and expectations. I think also just imparting a sense that I care in a genuine kind of way will amplify the placebo. But any advice about how our listeners can deliver better placebo effects?
Well, I think I'm repeating myself here, but there may be a point to that. I think you want to offer the treatment with a reasonable degree of optimism and positive spin. So say, I'm giving you this medicine. You should feel significantly better, within a week or so. It is a lot better. It creates a more positive expectation than if you say, try this, it might work,
Mm-hmm.
or to hand somebody in the primary care. This is a powerful painkiller. That's a very strong message rather than saying, try this, so people get better with it. So, I think simple sort of language issues come into play here.
And if you wanted to be transparent with patients, I suppose you can point out, look, even if something were a placebo, that's not no treatment. I always love Mauricio Fava's work on this, the open trial of placebo,
Right.
in depression, where you consent the patient and you tell them, I'm going to give you something that doesn't have any active medicine in it, but people often find it helpful. I want you to take it every day. You're going to meet with me on a regular basis. We're going to talk about how you're feeling. And then by week 4, he found a significant difference compared to waitlist, I
Right.
think was his comparison.
Right. There have been a lot of studies now, not only in psychiatry, as you point out, but also for pain syndromes
Yeah.
and some other stuff. Mostly in the last 2 decades, it's called, open label placebo. It used to be thought that, the history of placebo was that they were given openly in the 19th century. And for the first half of the 20th century, placebo treatment was a quote, legitimate part of medical care. This is before we had all the specific drugs we have now. And doctors were taught how to prescribe placebo. But in any case, with all the changes that took place in terms of ethics and so on, the idea got floated that in order for a placebo to be effective, the patient has to be deceived. They have to be told that it's a drug. But as you point out now, there have been a raft of studies giving people uh, what's called open label placebo, tell them that it's a placebo. And in most of these studies that have been published, at least, we don't know all of them, the openly given placebo does have some benefit. You don't lose all of the effect. And there's a whole script that you can give people that's very, very compelling for a lot of people, which is, I'm giving you this thing. It doesn't contain any drug, but, it may stimulate the body's own healing mechanisms or something like that. So you provide, and a lot of people improve with this. So you still are providing positive expectations, even though you're letting them know that it's not a conventional drug.
You make me think you're also tapping into perhaps a belief system about the things that we just don't understand. I'm thinking of all the people I can remember over the years interested in complementary and alternative approaches, and who
Right.
will want to convince me that vitamin C is where it's at, or if they just take magnesium or some supplement, and all these years I've kind of been, I don't know about that. I've been wasting an opportunity handed to me by the patient by not saying it's a great idea. You let me know what happens. I'm fascinated. I share your
Right.
your intrigue.
Right. I would say, and I wrote about this in my book, I would say encourage them to take the vitamin C or put magnets around their neck or whatever they want to do. But if they have a melancholic depression and they're seriously ill, say, but along with that, I would like you to take this Lamictal or venlafaxine or whatever it's going to be.
So this
So
does get into sort of choosing the right candidate for a patient. And in my understanding of literature, one predictor of not so good a placebo response, which is the same as not a good predictor of a drug response, is high severity and a history of treatment resistance. And even there,
that's true.
he doesn't work as well. But boy, I need every ounce of help I can muster. So I don't think anyone's going to rush out to do open label placebo with a high, severely ill, suicidal, psychotic patient. But on the other hand, if we think about the context in which we couch our presentation, if I'm going to give you a high potency treatment, ECT, ketamine, can I amplify it? Can I add some placebo augmentation to the ECT, do you think, in such severely ill patients? Get a little extra mileage?
Yes, if that is consistent with their expectation. I mean, yeah, sure, absolutely.
You've also written about endurance of the placebo effect, that there's a common perception that it's transient. And you published a paper saying, well, at least out to 12 weeks, something like 80% of people hold on to their response. Uh, any tips you can share with our viewers and listeners
Yeah,
about
yeah.
how to sustain that?
It's not. I mean, all of the data that we have, and it's not is that the placebo response is not transient. It isn't that simply people will feel a little better for a short period of time. It's quite persistent when it's been looked at over time in clinical trials. And in fact, everybody who's done a significant number of clinical trials which are placebo controlled has an anecdote where they broke the blind, the trial is over, and patients on placebo asked to continue on it.
Mm-hmm.
They say, and you tell them, well, I just need to tell you what you got in this clinical trial was placebo. Doc, I don't care what it was. It made me feel better. I want to
Mm-hmm.
continue it.
Wow. Um, so in terms of who's not a good candidate, I think you and others have written about severe cognitive symptoms, psychotic symptoms, suicidality, where again, I think we temper our expectations because response rates in general, and for a lot of our viewers and listeners, I'm sure, are in mental health, are seeing patients who've not gotten better with other things. How do I phrase this? Placebo should be started sooner than later. It's not the 14th thing you want to try, or, well, not as a monotherapy anyhow, but judge when and how you expect to capitalize off its potential benefits in the trajectory of sequential treatments.
Yeah, we haven't talked about this, but I think there are very few situations where one should actually prescribe placebo as the first or fundamental treatment. That's not to say that one should not try to enhance the placebo effect in all treatments. Not just but to just give a placebo. I think there are some situations where I think that would be appropriate. Where the condition is highly placebo responsive, where there isn't a conventional treatment that is clearly going to work for this patient. I think those are instances where you might want to consider that. But I think more relevant to the everyday practice of medicine and psychiatry is how to harness the placebo response in the context of ordinary treatment,
Mhm.
not how to give a placebo. I think there are times when probably a placebo treatment would work. And by the way, speaking of suicide, I'm sure you're aware there are a number of studies that have shown that suicidal patients, when suicidal patients are discharged from the hospital, they are less likely to attempt suicide again if they get fairly infrequent phone calls just checking in on them, which suggests that even something like suicide or suicidality can be quite responsive to sort of, non-specific supportive interventions.
Messages of hope.
Yeah,
I
for
mean,
what
to
that's.
take it back to Aaron Beck, I mean,
Yeah,
hopelessness at its worst point tends to be
right.
the enemy here. So anything, I suppose, when you're checking in, it's also saying, "I believe you can get better. I'm still here." It's not just about I haven't abandoned you. It's that I'm
Right.
looking to see if this is working because I believe it's working. At least I believe it has a chance to. As long as I have that hope, maybe I can, through osmosis, if nothing more, impart that on to the patient. Um, so just one or two last things here. So yeah, I don't think I've ever knowingly given a patient a placebo, but I confess I have given patients medicines that I know have smallish effect sizes. I'm not going to name any specific medicines. We could both probably
And I
think of,
think most docs have done that. That they give
and
a medicine, they think, look, it's not going to work because of its inherent therapeutic value, but at least I'll get something like a placebo response out of it. I think that's done very frequently.
yeah, I'd agree. And it sort of gets the interesting way that clinician prescribers do their own risk benefit analysis. And, in the bipolar world, for instance, uh, those of us who've written about lithium and talk about it really works better when started sooner. But then some would say, well, but there's all these side effects with it. So I'm going to hold off on this heavyweight treatment and give you something milder. It may even be something that hasn't been shown to work in randomized trials. There's a few drugs that people I know do prescribe in bipolar illness that would not be the first or second or third line option in a practice guideline because they really haven't been vetted and shown to have either clear superiority to placebo or a meaningful magnitude of difference in terms of the effect size. But I want to spare you side effects. So I'll give you something that I think is going to spare you side effects. It's a gesture in some ways. In my mind, those interventions are okay when patients are not severely ill and when they're engaged in the treatment, and you have your eye on the ball and you're paying attention to, well, if they do
Right.
clinically worsen, I may need to step up the game. But with those small effect size drugs that may not have been as well established, I am sure banking on every ounce of placeboism that I can muster to try to get something going.
Yep. That's
The
good.
art, the art and the science. Well, this has been eye-opening, as so often is the case. I love what I get to do and hear from colleagues who've spent so much time here. Do you see anything about the future of placebo effects? I mean, the pharmaceutical industry works so hard to suppress them. We clinicians want to be cognizant of them. If we want to try to capitalize on them, especially whether you're an investigator or a clinician, is there a future for the placebo effect?
Well, one of the axes that I like to grind here is, and we didn't talk about this, but whereas expectation is what far and away the most studied feature of the placebo effect mechanisms,
Mhm.
conditioning also plays a role, classical conditioning, and you could have conditioned drug responses. And there have been a number of pretty good systematic studies which have shown that you can condition drug responses. That is, if somebody's been on an ADHD drug or an immunosuppressant or I don't know, there's a couple of others, and then you substitute a placebo for some of the drug, you retain the effect
Hmm.
as a result because if you substitute placebo or some other feature, you the placebo becomes a conditioned stimulus to the
Yeah.
response. That's a familiar concept here.
Has bearing
And
you want to pull back on a dose, perhaps too. So I'm coasting along at my 60 or 80 milligrams of fluoxetine, and if I drop that by 25%, I don't necessarily assume I'm suddenly going to get a 25% decline in efficacy if the
right,
patient's doing well.
and according to the research that's been done, and it's not a huge amount, but this if you drop the SSRI by 20 milligrams and substitute placebo, you don't lose the response.
Hmm.
So that the placebo is becoming conditioned stimulus. And what this shows is that you could uh, give people far lower doses of drugs if you use this conditioning model than you now use. And as a result, it would be less expensive and it would also save them side effects. But that has not really been tried in clinical practice.
But it's certainly something our viewers and listeners might want to think about, not to rush out tomorrow and just drop everybody's dose. But if the occasion arises, if the issue of deep prescribing comes up, or gee, I'd like to be on less, if you're starting from a place of wellness and the patient's got an established baseline now of doing well, it may not be so outlandish an idea to say, well, we can cautiously do this. And I've got my finger on the placebo button. However, I can impart that to you, whether it's tangibly or interpersonally or just by otherwise conveying, the safety net. We can do this, and we may be able to win-win if we can spare you some side effects. I'm on your side. I'm here to help and sustain the benefits, which is really what we're all trying to do.
Right. I mean, I'd be happier about that approach if there was some more data which actually show that it worked. But I think that's been an understudied and underutilized approach.
It's going to be tough to do
Drug
funded
conditioning.
trials of placebo versus no treatment.
Right.
We almost need those, don't we?
Yep.
Just to really help tease out these active ingredients. I'd love to see some studies looking at immunomodulator biomarkers of the placebo responsive patients at different points in time. To some of the things that you were saying earlier on. So it's fascinating stuff. Dr. Brown, I want to thank you so much for taking the time to join us today. Any final comments before we wrap up?
No, but I think the idea that you should consider the placebo effect and placebo response not a nuisance, which is what has been thought of for a long time, but as an important part of all healing, and it should be enhanced.
It's a third of the effect. We'd be remiss to not appreciate and recognize that and use
it. Absolutely.
Wonderful. Well, again, I want to thank you so much for joining us today. I want to thank all our viewers and listeners for taking the time to join us. I hope you found this helpful, and we will look forward to seeing you again real soon on the next episode of Brain Trust Conversations in Psychopharmacology. I'm Joe Goldberg. Thanks for joining.